Welcome to Pulse and Pressors, where critical care gets crystal clear. Distributive shock originates from a collapse in vascular tone and widespread maldistribution of flow. Even with high output states, pressure and perfusion fail at the tissue level. The core physiology centers on vasodilation, capillary leak, and a profound inability to extract and utilize oxygen. The circulation becomes fast but ineffective, and tissues suffer despite seemingly adequate flow. Hemodynamically, these patients show low SVR with high or preserved output early, transitioning to low output as myocardial suppression and mixed shock evolve. Lactate elevation reflects both hypoperfusion and cellular extraction deficits. The distributive pattern emerges from distinct mechanisms: septic inflammation, anaphylactic mediator release, or neurogenic autonomic collapse. Each produces vasodilation, but with unique physiologic fingerprints. Septic shock reflects dysregulated inflammation, driven heavily by eNOS and iNOS pathways producing nitric oxide and severe vasoplegia. This underlies catecholamine resistance, where receptors and intracellular pathways become less responsive despite escalating doses. Echocardiography reveals a hyperdynamic left ventricle and brisk inferior vena cava collapse, distinguishing this from cardiogenic etiologies. A preserved TAPSE helps differentiate early septic physiology from right-sided pump failure or late RV suppression. Perfusion failure arises from lactate generation, mitochondrial injury, and endothelial dysfunction. The degradation of the endothelial glycocalyx is central to capillary leak, microvascular injury, and impaired oxygen transfer. Fluid strategy must rely on dynamic responsiveness rather than static numbers. Capillary leak evolves rapidly, and repeated reassessment is essential to avoid worsening edema without improving perfusion. Vasopressor therapy begins with norepinephrine, but vasopressin provides potent V1 receptor-mediated vasoconstriction independent of pH. This becomes especially valuable when acidosis renders catecholamines less effective. Anaphylactic shock results from mast cell mediator release, causing airway swelling, vasodilation, and capillary leak. Epinephrine remains the single most important therapy because it addresses all three simultaneously. Neurogenic shock's unique physiology comes from loss of sympathetic tone and resultant vasodilation with bradycardia. Treatment focuses on vasopressors and restoring chronotropy. Several conditions mimic distributive shock, including ACE inhibitor or ARBs. Vasoplegia, adrenal crisis, high-output cardiogenic states, and unrecognized hypovolemia. These must be identified early to avoid anchoring bias. Typical bedside findings include warm extremities, flush skin, wide pulse pressures, and elevated SCVO2 from extraction defects. These outward signs are often the earliest clues to vasoplegic physiology. Failure to respond demands reevaluation for occult bleeding, adrenal insufficiency, tamponade, or pulmonary embolism. These masqueraders frequently appear when distributive shock seems refractory. Management integrates source control, antimicrobial precision, optimized vasopressor selection, and focus on microcirculatory perfusion. Timely intervention is crucial to prevent transition to multi-organ collapse. This is Pulse and Pressors, reflecting on the marvels of the human body. Subscribe to stay sharp.